Good morning, everyone, and welcome to today's Day of Dialogue, and specifically to the panel discussion on addressing health disparities. My name is Teleandre Thomas. I'm a CASE alum from class of 2002, and I get the opportunity to serve as your moderator today. The conversation will consist of 5 esteemed panelists from various departments from across the Case University, and we'll introduce them shortly. Just a little bit about myself. I bring about 15 plus years of experience in healthcare as well as public health. I've had the privilege of working very deeply in and across community throughout Greater Cleveland and with some of our most prestigious institutions, including university hospitals, which was then Ireland Cancer Center. Now, as you know, it's Seidman Cancer Center, the City of Cleveland, Cleveland Department of Public Health, the Center for Reducing Health Disparities, as well as the Sisters of Charity Foundation of Cleveland. Ultimately, my work, my passion, and my commitment has been around trying to understand the burden of poor health outcomes, particularly among our African American community, address the disparities and identify the root causes and inequities, and help to bring about interventions and policy solutions to ensure that all people can reach their full potential. Today, in the Day of Dialogue, it's been created by CASE with the intent of creating an intentional space to bring members of the campus community together to engage in critical issues that are impacting our lives, whether that be civil unrest, social injustice, a global pandemic, economic recession, and other challenges, that may impact us individually, collectively, and as a university community. There are multiple sessions and discussion spaces being hosted today. The Day of Dialogue will conclude with a panel where university leaders will discuss the key themes and questions that have emerged throughout the day. And for the next hour, we are inviting you to engage with us in a conversation regarding health disparities. When you registered, you had the opportunity to submit questions in advance, and so we thank you for doing that. I will do my best to make sure that those questions get asked and answered in the conversation. As other comments and questions arise throughout our hour together, you are invited to utilize the chat box, and we will check that from time to time and connect with you in that way as well. The last thing that I would ask is that you just be mindful of the space we're trying to create today, that you respect people's voices, their experiences, and approach today's dialogue with the intent to listen, learn, and contribute. So with that, I'm going to get started and offer just a little bit of a framing for today's conversation, and then I'm going to shift to our panelists. But in order to get started, I thought it would be helpful to at least just do some ground setting and bring to bear a couple of definitions and common language for the conversation. So first, I just want to lift up health disparities. And I'm going to leverage the definition and insights that come to us from Healthy People 2020, which is a widely accepted definition and widely utilized resource in this space. So when we talk about health disparities, it's really defined as a particular type of health difference, a health difference that's closely linked with economic, social, and environmental disadvantages. At the end of the day, health disparities adversely affect groups of people who have systematically experienced greater social or economic obstacles to their health based on racial or ethnic group affiliation. It could be their religion, it could be socioeconomic status, or otherwise. When we talk about health equity really is the underlying principle or the commitment to reduce and ultimately eliminate the disparities that we see in health amongst racial and ethnic groups, as well as particularly focus on the determinants that drive those disparities. When we're pursuing health equity, when we're addressing health equity, it really is about a commitment to strive to achieve the highest possible standard of health for all people and give special attention to the needs of those at the greatest risk for poor health outcomes based on social conditions. And then the last thing that I would lift up before we get into the conversation is that social determinants of health are the conditions in the environments in which people are born, in which we live, in which we learn, work, play, and or worship, as well as age. They affect a wide range of our health, including the quality of life of outcomes for us. These could be social, they could be economic, they could be physical. I won't get into a long list of disparities and inequities for the sake of time, but I will note that nationally we have seen consistent trends in disparities for chronic disease and morbidity, overall life expectancy, and here locally in the city of Cleveland, as well as even within our state of Ohio, we acknowledge and we have studied that life expectancy gaps exist between Black and white residents, and we can trace that down to area codes, some which sit in the shadows of the very university, which we all are attached to. In addition, we are having ongoing challenges with infant mortality, particularly for our Black babies who die at almost 3 times as high as rate before their first birthday than their non-Black counterparts. And then we also have challenges around lead poisoning, as well as economic stability and opportunity. So I'm really excited about today's conversation. I am thrilled for the wealth of knowledge and expertise and passion that the panel brings. And so with that, I will ask our panelists to introduce themselves, sharing their name, their title, their tenure and affiliation at the university, and also respond to the question, as you reflect on the historical events of 2020 thus far, namely the coronavirus pandemic, the social justice movement, and the economic fallout. Can you share with us how these events have impacted you personally? And if I may, can I invite Dr. Miller to start us off?
I knew you was.
The spirit moved me.
Thank you very much, Ms. Thomas. My name is David Miller, and I'm a faculty member and associate professor at the Jack Joseph and Morton Mandel School of Applied Social Sciences here at Case Western Reserve University. Area of research is around cancer disparities, particularly involving prostate cancer awareness and knowledge among minority men. And as you mentioned, the disparities in that particular area are very great. In terms of, the question of COVID-19 and social justice, I'm working on an editorial right now where I link both of these and intersect them as a virus. And the virus of COVID-19 is spurring a lot of activity from a scientific standpoint, looking at the development of a vaccine, yet the virus of racism isn't going to be solved in a lab. And we really need to take a look at and have these really hard discussions that we are starting today and move beyond just the statements that individuals are making to some really hard decisions about what this country is going to do regarding racism, regarding how that virus continues to spread and create anger, creates an environment where about Black men, regardless of MD, JD, PhD after our name, if we're caught by someone who sees us as a threat, that virus begins to react in them to the point where we can find ourselves with a knee on our neck or a bullet in our back or beaten up. So this situation has really brought to bear has opened the eyes and exposed all of us to something that is a reality that many on this panel experience every day and have a history of. And I hope that this day of dialogue will begin the process so that not another Black boy, man, girl, woman ends up dead and a mother has to bury her child, and a community cries for justice. We can't do that anymore. It's gone on for too long. It must stop.
Indeed. Thank you so much, Dr. Miller. So I'm just going to move down as my screen is projected. So I will invite Shanina Knighton to introduce herself.
Hi, I'm Dr. Shanina Knighton, and I am a clinical nurse scientist, faculty in Francis Payne Bolton School of Nursing, and a KL2 scholar. My research area is in infection prevention, and particularly I focus on developing self-management technologies to help disabled people, people with barriers, to be able to do things that other people, and I would say normal people, wouldn't be able to do. So what that means is, like, right now, my focus has been on patient hand hygiene. Many people don't know this, but patients that are in healthcare settings do not have access to be able to easily clean their hands. And so a lot of the work that I do is centered around that right now. As it relates to COVID, as it relates to racism and what's going on, my research, while yes, is in a hospital setting, has shifted to be inside of the communities. And I have heard a loud cry from communities in that the misinformation, as well as lack of information or assumptions that information regarding infection prevention would make it to our communities, has not. So a lot of the work that I've been doing has been hosting webinars for small businesses, particularly businesses of color. It has been getting out in the community, providing infographics, because I understand the literacy levels. And just as my colleague, Dr. Miller, alluded to in regards to African Americans, I've been on the receiving end of police brutality. Every male in my family, except my husband and my nephew, have a record. And I can tell you that literacy has played a big portion of that, not because the individuals in my family are bad. So when I look at the current situation and the current climate of what's going on in COVID, as well as racism going hand in hand, I also look at the people that are scared to go inside of a facility, the people that are scared to wear masks because they'll be racially profiled. And so there is quite a bit to unpack here, and I'm looking forward to learning from you all, as well as being able to share my expertise on the topic. Thank you.
Thank you so much. And now, Dr. Blanton Tolbert, please.
Good afternoon, everyone. My name is Blanton Tolbert, and I'm a professor in the Department of Chemistry here at Case. My area of research is I study the biochemistry and structural biology of RNA viruses, like the virus that's responsible for COVID-19. I started my research career, my independent research career, studying HIV, the virus that causes AIDS, which is another virus that disproportionately impacts the Black community. I think Dr. Miller summed it up as to what my cultural and social experiences have been. I won't go into that, but what I will say is that my connection now to this moment in history is that I get to be actively involved. So my lab is actually carrying out basic science, basic research to understand how the virus that causes COVID-19 infects cells. And we're attempting to identify ways where we can inhibit the virus with novel antivirals. I'm also engaged in the process by my affiliation with the NIH Advisory Council, the Office of AIDS Research. And in that position, I get to have a voice. I have a seat at the table. And these topics are quite common, health disparities and viruses like COVID-19 and HIV. So it's deeply personal for me. I'm from South Carolina, so my background, I've experienced different levels of racism throughout my life. And so now to be actually here, having this conversation with you, a professor at Case, it's an awesome moment. And it's one that I'm just thankful that I have this opportunity and to potentially have an impact and be a role model. So with that, I'll pass it on.
Great. Thank you so much. And I would like to invite Dr. Emmett Jolly to introduce himself, please.
Good morning. Thank you for having me and thank you for having this really, really important discussion. My name is Emmett Jolly. I'm an associate professor in the Department of Biology. I've been an adjunct appointment in the Center for Global Health and Disease in the School of Medicine. And my research focuses primarily on parasitic worms, as well as African sleeping sickness. And one of the reasons why I chose this area was because these are diseases that primarily affect poor people and people of color. And one of the things that I thought that's really critical for these is to have people who have expertise in biochemistry, genetics, and cell biology, and use those toward diseases that affect poor and minority populations. To your question, how does this affect me? To be quite frank, I am quite angry. I'm upset. I go through the mixed feelings that I think all of my colleagues go through, wondering not only why, but how much longer are we going to have to deal with this? I want to expand on Dr. Miller's analysis of a virus. I would say that it is racism that is the virus, and we are immunocompromised host for the HIV person, Dr. Blanton. This virus is consistently spreading throughout our national system. And unless we find a way to boost the immune system, to basically force the body to affect this virus that is consistently spreading throughout our body, that we are going to be consumed by racism. Mm-hmm. My take on this right now is that what we're going through reminds me of the Post-Reconstruction Era. Mm-hmm. And I think even as scientists, as physicians, and I'm not a physician, that we have to take a look at the past in order to see what is happening again in the future and in the present. Post-Reconstruction, as you know, initially during Reconstruction, you had African Americans who are now in the Senate, African Americans who are in various politics. There's post-slavery, so now there was this new transformation, this new group of people who were being successful. And then after that came that post-Reconstruction era, where you had this anger that developed as a consequence of that and the birth of the Ku Klux Klan. Right now, we just had one of the most momentous occasions in our country where we had an African-American male president. And you can imagine what happened immediately during that time. The surge of racism expanded so profusely. It is now consuming us once again. When Obama was elected for the second time, my father, who worked at the University of Alabama at Birmingham, went into his office and found a noose waiting for him in there. This is the state of where we are. And we have to look at this from the perspective of the need for a new civil rights movement, and healthcare being one of the most important places where people, due to systemic racism, has now led to people having these ongoing chronic diseases that are not addressed in an equal and equitable fashion. So how does this affect me? I'm frustrated. I am motivated, and I am looking forward to trying to be an agent of change as we move forward.
Awesome. Well, thank you so much for sharing. And lastly, I would like to invite into the conversation Dr. Margaret Larkins Pettigrew.
Good morning, everyone. I'm Dr. Larkins Pettigrew, and I am an obstetrician gynecologist at University Hospitals with a specialist in HIV. I take care of women living with HIV. I'm also had a few more hats. I actually am the Chief Diversity Officer at the University Hospital System. And there's a lot that goes with that, of course. And then my affiliation at the Case Western Reserve University is that I am one of the assistant deans in the School of Medicine, and I have tenured here for about 10 years. I am the diversity officer at University Hospital, which puts me in the pit of all of the stuff that goes on around, equity, community impact, diversity, and inclusion. So in that space, of course, I'm dealing with these struggles every single day. We can't, and I really applaud all of you, being able to say racism, which many people can't say, is important for us to say. I look back at the history of our country, which Dr. Jelly alluded to, and the number of people who died, coming through the middle passage, 2.5 million people. The other 4 million that died here in slavery, not to include the people who died on the shores of Africa before we even got here. And fast forward and all of the lives that have been lost through the lynchings and the Jim Crow. And at this point in our lives, this is just something that has occurred over and over and over again. And hopefully this is a point where not only are we telling our story, but everyone, both Black, white, no matter where you are, have been affected by racism, meaning that everyone has a lived experience around racism, not the tremendous burden that African Americans, people of color, have carried, but the burden of, not even the burden, but the presence when there has been some racism that they have looked at blindly, because everyone who lives and breathes today has been exposed to racism. And they have chosen to ignore it. It's like this blind spot that they said, okay, I'm okay, so I don't have to engage in this. Mm-hmm. And what that has done through the 400 plus years is that it has really put Black people where this country has wanted us to be. There's a very disenfranchised group of people who helped build this country, but really are not citizens of this country because of the way we have been treated. And I hopefully this is the time that we can really pivot and really think about and have conversations around racism, around the whole issues of why our Black babies are dying at such significant numbers, because that's the space I live in. I see the entire spectrum of how this country, this social construct of racism, has destroyed a people and continues to do that. And this pandemic that we're talking about, absolutely, COVID has uncovered a significant amount of stress that we have been under for a long time, that we have seen over and over. But the pandemic, in addition to the COVID crisis that we need to deal with, is this pandemic of racism. This issue of the fact that we need to begin to dismantle racism as a country, all of us, because if white people are not at the table, this is not going to happen. And so I can give you my lived experiences, and many of you on the phone can do the same thing. I mean, I have a son who had a stroke and who didn't get taken to the hospital, visible stroke, who said, you need to lose some weight. I have a daughter-in-law who almost bled to death. I can go on and on and on. 52-year-old father who died of massive heart attack, who was only given aspirin after his first heart attack. So, I've lived through the civil rights movement, and I think I'm the oldest one on this call. But this is the time where it's more than just the talk. If we are going to move towards some resolve, everybody has got to say come out of their mouths to say racism we have to dismantle racism, and we have to lift up the people who have been disenfranchised for many, many years. That doesn't mean taking away from other people. It just means that we need to make sure that we have our eyes wide open and that we see what's happening. The fact that, this happened to George Floyd, I mean, I have pages and pages of my history of people that's happened over and over and over again. Mm-hmm. So, this is a living, breathing experience in all of our hearts and all of our minds. We all had, my children been arrested. They're all well accomplished, but they're all Black men. They have felt that. They have felt the pressure of the handcuffs on them, right? I mean, I wake up every day as a Black mother, still today, and my oldest child is 49, praying that he doesn't take his last breath before I do, because this is the country we live in. And if we're going to have all this dialogue, it is about not only listening, but hearing and really having a deep dialogue around how we move from this to some resolve. So I didn't talk about my research a little bit, is around food insecurity, maternal morbidity, mortality. So really about trying to make sure that we have better lives, because it's got to change now.
Absolutely. Well, thank you, Dr. Pettigrew, and thank you everyone for your introduction, for the work that you are doing to collectively make lives better, and particularly amongst the African-American community. There's so much that we can cover. We have about 35 minutes to try to get into a combination of questions from students and staff members at the university, as well as some that I wanted to pose to you all. So I'm going to throw this first question out and kind of start with a localized lens, if we could. The university sits in the heart of University Circle in a city called Cleveland. And in Cleveland, in some ways, we are very healthcare rich. We boast high quality centers of medicine. We have research, we have innovation. CASE is a representation of that. So with that being said, though, what would you say, or what do you think Cleveland is leading in, and where do you think we have ground to gain, particularly as we look at it through the lens of health disparities and health inequity? And I invite wherever the spirit moves to speak first.
I want to start with the last part of that question, because we know about the great health care we have here, but the disparities of health in this city are very evident. If you live just south of Cleveland Clinic or University Hospital and do not have health insurance, you might as well be on an island in the Pacific Ocean, because you cannot access that world-class health care that's right at your doorstep. We have, as you mentioned, by zip code, Huff and Lyndhurst, which are about 5 miles apart, a daily run for some of us. And the life expectancy is 20 years difference. And in between that 5 miles, you have University Hospital and Cleveland Clinic. So while we champion these facilities, let's be clear. If you don't have health insurance, you cannot access those facilities. If your health literacy is low or non-existent, interacting with the physicians who may not look like you is difficult and leads you away from seeking the care that you need. Oh yes, it's great. Everybody on this panel has access to that care. But if we go and knock on the doors north of Chester, can they access the clinic, UH? Or south of Carnegie, can they access it? We need to do a better job of making sure those individuals who live in those communities can access that health care. And just one quick point that many of us know Dr. Bob Haney. There's a school not far from the clinic. When the young men and young girls walk out of that building, they don't see Cleveland Clinic. They see the juvenile detention or justice center.
Across the street.
That's the optic that they receive. So let's be clear. We've got great healthcare here. Yes, world class. People from around the world come here. But if you live here and you don't have resources, you cannot access it. And that is wrong.
Thank you, Dr. Miller. Anyone else like to? Please.
Yes. So very well said. The only thing that I would also add in terms of what it is can be done better is we have to, when we're talking about something being systemic, we have to remember that systemic didn't just start yesterday. So systemic meaning are algorithms. So the U.S. uses commercially based algorithm systems that are automatically going to cancel out Black people. It's been shown. There was a 2019 study that showed that the way that we receive care, and I'm actually going to read it, that bias occurs because the algorithm uses healthcare costs as a proxy for healthcare needs. Less money is spent on Black patients who have the same level of need, and the algorithm thus falsely concludes that Black patients are healthier than equally sick white patients. I'm bringing that up to say that here it is, if our system has algorithms in place to where my family members, because just as you mentioned, I don't even have to go next door, Dr. Miller. I'm a first generation to finish high school. So I have these people in my family that don't have access to healthcare that I'm constantly advocating for. And when you go inside of a healthcare system, as you mentioned, whether it's a Cleveland Clinic or a UH or any system in Cleveland, and someone tells you your mom or your dad is lucky to have you, and my response is I feel bad for people that don't, that means that there is a disparity, and I'm constantly struggling with that. I work inside of these systems, and that I know that our people are not getting help. So what I encourage is, just as you mentioned, we do have insurance inside of these systems. We're incentivized as employees for being able to keep our wellness up. But I challenge all of these great things that we have in Cleveland. How do we incentivize our communities? How do we incentivize our communities to say, okay, hey, did you check the ingredients inside of your vitamin D? We know that maltodextrin leads to spiked sugars. So what does that do for a person that has diabetes? For the kid that's going to have the potato chips, is getting ready to have the MSG in it, what is that doing to ADHD? I can say azodicarbonamide because I know I have some chemists on, here with Dr. Jolly. So I think we talk about all of these things, but we're not talking about the very foundation of the problem, with that being our food, with that being education, which we know literacy has been an issue from a long time. We can talk about just even the things from our children learning early on, where they're still playing hangman in school and still interpreting Baba Black Sheep, which we know are racist. And so these very foundational things, when they're reading poems about the white sheep being better than the Black sheep, what does that do to their mental psyche and then being able to see themselves in regards to being able to obtain good health? So when you feel like you're doomed, how do we, with resources in Cleveland, change the story and change the narrative to say that we're going to be more community oriented when we know that it is these health issues that keep healthcare systems functioning? So we have to move somewhere from being a treatment-based system to being a preventative-based system, to where we understand the same way that we look at these antibiotics, antibiotic on top of antibiotic means that we're making more and more antibiotics. At what point does our goodwill run out with antibiotics and antiviral drugs? We have to start paying attention to the fact that our bodies are made of chemicals and that we have to be responsible for what we're putting in them, and we have to educate people on what they're putting in them. But we have to be able to move past this first with even the health literacy. There's no reason why a HIPAA form should be written at a college level, but we have people that we're trying to service to where it needs to be at a third grade level. The policies that we're asking people to vote on healthcare-wise, I should not have to go to the polls and see how to shall thou. And I'm trying to figure out if I should vote for something or vote against it because it's not written in plain English. And so when I look at things that we can do better, as a holistic system, we can bring people into the conversation and meet them where they are. So that is something that I feel as systems, despite all of these resources that we have to do better about taking care of people at all levels.
Thank you so much, Dr. Knighton. You touched on a number of points and raised a couple of things that I'm going to circle back to, related to bias, related to structural racism, not only within healthcare, across a number of systems that impact quality of life overall. Before I move away from this question, is there anyone else on the panel who would like to add a thought? Okay, well, I will take that as consensus that we can move on. And I want to bring in the voice of one of our undergraduate students by the name of Courtney. And she asked the question to the panel, how does CREW address unconscious and conscious biases within health education, both at the undergraduate and graduate level? And is there a way for every pre-health student to discuss the social determinants of health and how they affect access to care? Anybody would like to respond to Courtney? Dr. Jolly?
You notice how quiet everyone was on that. We commend Courtney on providing the right question to shut us all up. What I will start off with is that there are two different things. One is things in terms of health bias, and one is bias in general. I would say at this point, I'm at least happy that the university has some bias, some general basic bias training. And this becomes critical for things like simply hiring people, for getting people in these positions. That being said, I will say that it has not gone far enough. Many often will take the basic amount of training and move on and not think about it and say, I have a credential that says now I'm no longer biased. But I think that in terms of my opinion, and I'd love to see Dr. Larkins' opinion on this, is this essential need for us to really train people to understand their own biases, to understand and empathize and sympathize with other people around them, to realize that whenever we're defining or developing policies, that we have to think outside of ourselves and think about how the policies that we produce and affect other people. In terms of healthcare, I would say if you are unable to get past the basic bias understanding, the challenge with healthcare is even greater. And I'll stop right there because my assumption is that Dr. Larkin has a lot more experience in that area than I do. And so I will defer to her.
So being part of academia for a long time, I can tell you that it has to start from the top. We as an undergraduate institution, as well as a postgraduate institution, people come from all over the world to be educated here. And so we all come with our own blind spots. And I can tell you that, from the moment people walk into this institution, we should be having these debates and we should be having these conversations. Mm-hmm. But it starts at the top, meaning that we need to hire more of us, because at the top is where you formulate all of these policies and procedures that trickle down. Mm-hmm. And so the problem is that if we don't have faculty members, and we see that every single day, if we don't have faculty members that are awake, then that's never going to happen for our general body. And so this issue of making sure that we're kind of making sure that we're talking about this on an ongoing basis has to be an intentional investment for the institution itself. I believe it's there, and how we do it is really going to take some significant strategic planning. We have some great new people in place, and I'm so excited that we're heading to not leaving an old regime, but a great regime as well, but that we're heading into a new regime that is facing all of these major issues. But even at the medical school, if you have educators who continue to talk as if we are living in a time of slavery, that's a problem. And remember, we are the educators of the world. We are leaders, and we are making policy. And if we are teaching our undergraduates as well as our postgraduates that we can continue to make policies that continue to put people in these disenfranchised groups, it's always going to happen. So it is the intentional investment of the institution to hire more people who not only look like me, because that's going to take a long time. I'll be dead by then. But hire people who have the same heart that I do. Mm-hmm. Have people who really understand, and if they don't understand, are willing to invest in understanding, so that it starts there. Because this is a long road. When we talk about implicit bias, I talk about implicit bias all the time. Now that I've entered this realm of bias, because we all are biased. But when bias kills, when bias hurts, maybe unintentionally at times, we really need to check ourselves, check our departments, check our institutions, and make a difference at that level. And that's where it starts. It trickles down from that. And then we use the carrot and the stick. You know, this is a time where there should be no tolerance of this behavior, none, right? And if we don't say that, if we say there will be no tolerance moving forward of racist behavior, of racist dialogue, of people not investing in these off-the-cuff things that they say every single day to students or in presence of students, that has to be this. Then it comes the stick, because they shouldn't be part of what we consider to be a great institution. So I'm talking about drastic changes, moving into a space where we are making significant differences and not tolerating any more of the lukewater, let's see, if they really meant this, or let's take some hardcore actions about changing behavior, because we are teaching our next generation. And if we don't do it here, when are we going to do it? So with that said, I hope I answered your question. I need to jump off to another town hall. It's been an absolute pleasure, you guys. I'm just so excited about being with the group. So you guys.
Thank you so much for your time and appreciate your work. Take care. Yes,
So,
yes, go ahead.
I want to chime in, and so I know that we are too talking about. So this is for Courtney's question.
Mm-hmm.
I believe that we have the infrastructure set up in our school, and I'm speaking of nursing. Okay. And I have seen it in medicine, and I've seen it in dental. The fact that they do have the dental clinics that are offered to the community. The fact that there is the free clinic. Even with one of the courses that I teach an evidence-based policy in a community course where my students go out and they take blood pressures, heights, and weights of students in the Cleveland public school system. And so prior to them going out, we have these conversations. There are students that may not feel comfortable taking their socks off. There are students that are saying, you know what, I don't want to lift my arms up because we didn't have water on and I wasn't able to take a bath. Mm-hmm. So to be honest with you, and I've expressed this, with different mentors, different leaders, and colleagues, the best way to get past a lot of these things is to be able to have a conversation of, again, where you can both listen and receive, but to also set students up for the opportunities that they otherwise may not see. Because while I understand we want to say, yes, more Black people should be in these positions to be able to help our own, we are still what's considered a minority in this country. So to say that you may not have a white provider at some point or have a provider of a different color, does that then mean that we have more minorities that are seen by minorities and now the system is overwhelmed and that's leading to more medical errors? So this is what I describe to be a complex system of where we have to think about those parts. So I think if we get more evidence-based programs that are in a community, more of our students, to Courtney's point, that are going to allow them to be able to go out, interact with others, that there in itself does cut down on some of the bias. When we hear, as professionals, our colleagues say, oh boy, here comes that patient again, or oh, sickle cell patients are typically the hardest patients, I question how many people, when they hear those comments come up, actually say something. But this is typically what happens. So if you can imagine right now with COVID being on everyone's back, oh, Black people die from COVID. I can only imagine what my white colleagues are thinking every time they see a COVID positive come through the door with chronic conditions. So we have to absolutely address it from a community standpoint of getting students into the community so that way we can cut down on the bias.
Excellent.
Can I just add one quick point? One of the points I would like to encourage everyone that's listening, that's a part of the university, students, staff, as well as faculty, there's a program, Diversity 360. It's not the end be all and end all, but it's a first step. And I encourage all students, staff, and faculty to participate in that program. And if you have, go back. And I'm sure that other programs are available on campus to do. And that, I believe, will allow an opportunity to have some of the dialogue as well as examining oneself. And as everyone has mentioned, we all have these biases, and we have to look at our own so that we can at least be honest with ourselves as we move forward. Because the time of talking, we need doing with the talk.
Indeed. Thank you both. So I want to bring another question to you from the campus community. This is coming both from a graduate student, and I believe someone also asked the question in the chat room. So thank you all for being active in the chat room and engaging in the conversation. But very plainly, it's a conversation of why does the campus allow race science? All of you have a research background. And to the point of the discussion that we were just having around bias, whether it's implicit or unconscious, there are things that we carry around where we make assumptions based on someone's race, their ethnic background, their cultural context, and quite often it's to the disadvantage, and I'm going to say to Black people when it comes to the quality of care and the type of access that we get. And so when you consider the field of research and science and asking the question, is there an actual genetic difference between us and other races and populations, that raises a lot of questions. So your thoughts on why the campus allows for race science, and do you think that it contributes to racist ideology, kind of promoting the attitude that there's a biological difference versus really naming racism as the leading underlying cause for the disparities that we see? And I open it up to the group.
So I hate to still be the first to respond, but I'm gonna respond. So one of the things that I think about, and this is me as a scientist, not even dealing with mice, but understanding how things go from the point of when they're studied in the lab up until the time that they're put out to the public, okay? For me, it does matter if you have an albino mouse or if you find mice behind the trash can on 105. So are we talking about a melanated mouse or are we talking about a white mouse, right? So now you have a mouse and you say, we're going to give it these chemicals. So we're going to create this drug for blood pressure. Now that you've found that it works well with this albino mice, so we don't even know at this point if there's a difference between a melanated mice and a white mice, right? But we're just going to say for the sake of science it is, because this is where we've been at so far. But this is, again, the foundational building of it. Mm-hmm. So you then take that mouse, you build up that medication around that white mouse, and then you test it on a group of white men, but then you put it in a majority population of Black men, and you wonder why they're stroking out. You wonder why here it is someone is getting clots or they're having certain issues. And so what I say is when I'm looking at what would be considered race science, genetic science, are we considering all of those variables at each stage? And right now, even as it stands, when we have pharmacovigilance, the fact that Google has to pick up how someone Googles their symptoms based off of a medication, how it reacts in regards to self-report. We know that minorities are not going to report their side effects. They'll 9 times out of 10 be non-compliant if something is causing them some sort of side effect. So when we look at that, what is it about that medication that is giving my Black patient a reaction versus my white patient? And you can even see, like, let's say it was something like, lisinopril. It's shown that the effect of that medication for Black people is different from white. Mm-hmm. So there has to be something there. Does it start at the level of the mice and maybe we're just not studying that enough? It's a possibility. But the thing is if we are going to say that medications are going to be used to treat, overarching, we have to make sure that there are enough diverse people within studies, within samples, in order to be able to determine that. And so I do hear, why do we have a race science? It's not to say that, okay, we shouldn't, but there are differences, unfortunately, whether that's regarding our diet and everything else that comes up that does cause us to investigate things a lot closer to understand what those differences are so people can get best treatment, especially considering this country has been built on European medicine and white medicine, which means that from the beginning, we were already excluded.
Mm-hmm. Great point. We have about 10 minutes left in this discussion, and there's at least 3 more questions I want to try to get in. But Dr. Tolbert, would you like to weigh in on this question?
Yeah, I would just like to add a comment there. So the National Institutes of Health, as a part of their review process of grant set, would involve clinical trials or human studies. They do take in consideration sex and race as a biological variable. So that's a very important point, I think, that needs to be made. And just to the multiple points that that Dr. Knighton made, we're talking today about health disparities and a virus. So it is very important that we have studies that include people from the exact populations that are being disproportionately impacted by these by these types of illnesses. But what I will say is it's equally important to have representation at the top of those studies, down to the nurses who might be collecting samples. If you don't have people that are in those positions that you can identify with, there will be challenges associated with it. Okay. And so that's something that we have to do a better job, in my opinion, is making sure that there's representation at every level of the process.
Great point. Thank you so much. So in about the 10 minutes that we have left, I want to make sure that the panel gets an opportunity to weigh in on the COVID pandemic in particular. From where you sit, what is your assessment on how Ohio in particular has responded to the health crisis, and where do you think we still have some opportunity to improve in order to keep people healthy and safe?
Let me say that I appreciate and applaud the governor's use of science and willingness to follow the lead of science in this. I don't agree with his politics, but in this instance, he followed the science and used that to do within his power the best that he could, given the circumstances and the guidance that he received from Dr. Anton. So I applaud him on that. But what we also saw in Ohio was how another manifestation of the racism virus, when you have legislators, particularly in areas without large minority populations, if any, wanting to open up and do things that really place the state as a whole at risk. So when we look at what we did, or the governor did, that was showing leadership. However, because of, let's just call what it was, the racism of some of the state legislators and the leaders there to try to take the power away from Dr. Anton, who were anti-science, who were in areas that had very limited minority populations, saying, oh, this isn't such a big deal. That's problematic. And those individuals will continue to make the policies that will hurt individuals in this state, that particularly in the urban areas, regarding COVID-19 and the next virus or pandemic that follows, or the one that we have to deal with, that being racism.
Excellent. 30 seconds for anybody else who wants to respond to the COVID question before we start to wrap up.
I would say framing. So framing was a big deal. When you get somebody on TV and you say, don't go to the hospitals, when you get someone on TV that says, oh, stay at home, that has a different meaning for Black people than it does for white people with chronic conditions. the way that we tolerate pain, the way we manage our conditions, because we've been taught to manage conditions like that because of limitations of insurance, limitations of not having providers. These are things that we're faced with. So when we look at a lot of the deaths, they're associated with going to the facility too late to be seen. Some of these people are dying at home. Some of these people may not have been COVID-related deaths, but they're still deaths related to COVID because their hypertension was untreated, because they were stressed out about COVID and didn't go in to be seen about it. They didn't check their medications. So I think the framing that was not sensitive enough to certain populations to understand that there could have been unintended consequences of staying at home and not going inside of facilities.
And I thank you. And I saw Dr. Jolly's hand. Did you want to add to that?
No,
okay. Okay, great. So we are unfortunately nearing the end of the hour. And again, I said this could easily be a long conversation, and we've tried to cover a lot. First and foremost, we have heard, the consistent theme of the importance of naming racism and understanding it as a root cause. It's even been expressed metaphorically as a virus. We talked about the fact that disparities in Cleveland are very evident in spite of or despite the resources that we boast as a community, but understanding the disconnectedness in terms of what that means in access and otherwise for communities and populations that lie in the very shadows of these institutions. There also was a consistent theme, in my opinion, around the urgency of now, that there's been this long arc of history that generationally we all have personal experience with that goes back to the shores of Africa, a 400 and now 1 year history that has been passed on to us and narrated through the very DNA of our lives, but also our lived experiences. This dichotomy of community and institutions and finding better ways to meet one another where they are and to push back on policies, practices, and biases that have not served us well to yield the outcomes that we desire. And then I also heard the importance of representation and how that has to be intentional at all levels of the work, from leadership to those carrying out the practice of medicine, to those studying it, to those teaching it, and so on and so forth. So I thank you all for bringing all of those themes and insights to light. As we wrap up, I want to give everybody the opportunity to answer this question, and I apologize that you won't have a long time to do it. So if you could potentially respond in 30 to 45 seconds. I'm going to ask a two-part question. One comes from a graduate student by the name of, and I apologize if I'm saying it incorrectly, Jung Q, and the other is my question to you. So Jung Q asked, can Crew do better at rebuilding trust between community and around science? And then my question to you is really just a closing statement. If you could offer a word of advice or encouragement related to health and well-being, particularly to our Black colleagues, students, and alums, what would it be? So I'll start in the order that we began and offer it to Dr. Miller.
You're muted, Dr. Miller.
Yeah, I knew it. I would be the one that would be muted. It would happen. Okay. Yes, CASE can do better to build with science in the community. Although it's put on hold, the provost's strategic plan had a part to target the community and use science-based. Though we have to wait because of some other issues going on, I believe that leadership that he is showing with the strategic plan and that target can build better a connection between science and the community. And a word of encouragement is take care of yourself. Self-care is not selfish. And right now, with things going on, get and walk, get out and run. You know, I'm sorry, Dr. Knighton, I'm a potato chip holic, but we can put down the chips every once in a while. But take care of yourself. Mm-hmm. We only got one body, and our health is very important. So love on your health.
Thank you so much, Dr. Miller. Dr. Knighton, 45 seconds.
Yeah, so I would say, seconding what Dr. Miller said, I do believe that the strategic plan, focusing ways for us to get into the community, also talk about diversity are great. The fact that this was even set up today is a step in the right direction. Me even too, just reading over the provost and the president's statement regarding what has happened, I do appreciate them always getting in front of the issues and being openly and willing to discuss them even when they're uncomfortable. When I think about colleagues, when I think about students, when I think about alumni, regardless of whatever it is that they're doing for their profession, start thinking about it not necessarily from the perspective of descriptive, meaning let's not just describe racism, let's not just talk about racism, but talk about action. What are you doing to make sure that you can offset it? When I say that in regards to science, we don't need fancy geospatial analysis to tell us that white men die slower than Black men. We don't need anything to understand what it is we already know. You can talk to people and get those answers. But what we do need is actionable steps. What are we taking that are getting ready to be culturally centric, community centric, that is getting ready to impact change? So I question people to think about that. And that's on top after you've already taken care of the self-care that Dr. Miller has alluded to with limited potato chips. So.
Thank you so much. Dr. Tolbert.
So I think one thing that you heard from everyone on this panel is that your colleagues, as your colleagues, we live a dichotomous lifestyle. We walk through society as Black Americans, and we deal with the challenges of being Black Americans. And we are also your colleagues. We run research labs, we teach, we serve on committees. Now imagine our neighbors who live in the communities surrounding us, who don't have the resources that we have. So I would say, and I'm not sure if I'm really answering the question, but this is just sort of my anecdotal advice, is to have a little understanding and compassion. It will go a long way. As we're dealing with this moment in history, one of the things that I've always attempted to do is put myself in the other person's shoes and try and imagine what it would be like from their point of view. I would encourage everyone who's participating in this Zoom to try that. And let's see how we end up. And I will say I'm optimistic about the opportunities at Case, being in this community, and having wonderful colleagues that are present on this panel. I think there are many things that we can do better.
Excellent. Thank you so much. And Dr. Jolly.
Last but not necessarily least, I would say that there are many things that we can do on this campus to transform the campus. And that being said, I don't want to lead and say we have the worst campus on earth. I am proud to be a faculty member at Case Western. I am proud to have some members of the community who are engaged, who have empathy, who think about the broader campus from a perspective of equity and diversity. I am proud in part because President Snyder hired an amazing provost that we have right now who is developing a plan to try to make changes in the university. And being engaged in some of these committees, I can see firsthand some of the strategies and approaches that the provost is making. I'm proud that we, after having Marilyn Mobley here, who did an amazing job, now we have Robert Solomon here, and seeing him begin to define himself and try to make transformation in the university, and then to try to permeate that into the blood vessels of our institution. I do want to go back to Courtney's earlier question, because I think the second half of it wasn't answered, which was what can pre-health students do? And I would say engage. I would say the baby boomers took over this country as teenagers, and interestingly, they're still in charge. But having people who are young, who are smart, to engage with the community, to talk these issues out, to debate among these issues. Our young people are extremely smart. And in some cases, we need to look to them to learn from them. So Courtney, engage, participate as much as possible. And one last point, and this kind of reflects on something Dr. Tolbert said about being putting yourself in the other person's shoes. And I'm going to do it the opposite way. Poor people look to rich people and imagine, wow, life would be amazing if I were rich like them. Rich people look to poor people and say, they don't know all the problems that we have. But yet at the same time, I don't want to be them. And so what we have to do is look at each other, understand the need for the challenges that the other person has, but also understand the needs that we have. When we look at the inequity, people who are not necessarily caught, yes, we all have problems, but think about those who have greater needs in this unequal situation. So engage and share, and again, look at the other person's, walk in the other person's shoes.
Excellent. Well, we are a little over time, but I want to thank you all for sharing your hearts, for sharing your wisdom and your insights and contributing to this conversation. I must say, it's personally impactful to me because the representation I see on this screen is not the representation I knew as a student in the late 90s at Case. So the university is making grounds, and I want us to encourage to continue the university to grow in that facet. But thank you all for the work that you're doing. I want you all to stay encouraged and remind you to take care of yourselves as well, because we need you to. So thank you so much. And thank you to everyone who joined us on the call today. And we encourage you to connect to the rest of the dialogues throughout the day and the wrap-up conversation this afternoon with university leadership. Take care, be well, and be kind.
And thank you.
Thank you.
Thank you.
Thank
It's
you.
been my pleasure. Thank you so much.